Okay. Shall we start? Right. So today we are going to discuss about an important image-based questions. Okay. This will be very useful for your entrance. So shall we go now? Right. I am proceeding to the. It doesn't mean that I am going to teach you only image. There are so many videos in it also, right? So it will be easy for you to understand them, right? So let me start. 6-month-old brought with history of fever and cough, respiratory rate 60 per minute plus video. So what is this video? Let me look at this video. What is this? This is called chest indrawing. I repeat, what is this? This is called the typical chest indrawing. Let me repeat it again. This is called typical chest indrawing that you need to know. Now, so let us presume that what are all the possible questions that can be asked now? Right. So what is this respiratory rate for a child less than 2 months, 2 months to 1 year, 1 year to 5 years? So if your respiratory rate is more than 60 per minute, 50 per minute, 40 per minute, so per minute, it is called as tachypnea. For this child, the age is 6 months old. So for a 6-month-old, the respiratory rate of more than 60 should be taken into account. So fast breathing is there. So for this child, respiratory rate is high. Respiratory rate is high along with the chest indrawing high. So respiratory rate is high, chest indrawing is high. Then what are all the things that we need to ask? Is there any danger sign? So what are all the danger signs that you need to ask? The danger signs are: 1, not able to feed, not able to feed, vomiting everything, vomiting everything. Then with respect to respiratory system, saturation of less than 90 per minute in room air. Saturation of 90 per minute in room air. Saturation of 90 per minute in room air, less than 90 per minute in room air. Stridor at rest. That is what they had given in INICET guidelines. Stridor at rest. So these are all the danger signs. Is there any danger signs for this child? No, there are no danger signs at all. There are no danger signs at all. So it comes under pneumonia. It comes under pneumonia. What is the treatment? The treatment is amoxicillin. The treatment is amoxicillin 80 mg per kg for about 5 days. 80 mg per kg for about 5 days. When you have red flags, when you have danger signs along with the fast breathing and chest indrawing, then you need to give a combination of ampicillin and gentamicin for 7 days. This is ARI control program. When the respiratory rate is normal, when there is no chest indrawing, and when there are no danger signs, then it is called no pneumonia. The treatment is just reassurance or observation. Reassurance or observation. Okay, right. So these are all the things that you need to know with respect to fever, cough and chest indrawing. That is your pneumonia guidelines. For non-severe pneumonia, I repeat, for non-severe pneumonia, It can be either fast breathing pneumonia or it can be chest indrawing pneumonia. The previous definition of severe, very severe, those things are all gone. Now it is called non-severe, severe. Severe means you have associated red flags. Non-severe means you don't have any associated red flag. So for fast breathing pneumonia, amoxicillin 80 mg per kg in two divided doses for 3 days. Whereas for chest indrawing, the same amoxicillin, the same dosage 80 mg per kg, but for 5 days. So this is with respect to our first question on ARI control program. Okay? Right. So again I repeat, look at this chest indrawing. This is typical chest indrawing. Apart from that, what else they can ask you? Apart from that, what else they can ask you? Two more things that they can ask you. What are all the two more things? Previous guidelines did not mention anything about V's, but the present guidelines mentioned about V's. If there is V's, you need to give salbutamol rather than antibiotic. So presence of V's means even when there is chest indrawing, you need to give salbutamol and you are not supposed to give any antibiotic. Previous guidelines did not mention about this. And again, an SpO2 of less than 90% is a red flag and you need to refer the child after giving a single dose of ampicillin and gentamicin. So question number 1 with respect to chest indrawing video you had seen, and this case is non-severe pneumonia despite presence of chest indrawing, because as per new guidelines you need to treat with oral amoxicillin. Previous guidelines mentioned that chest indrawing comes under severe pneumonia. It is not so. Non-severe, severe. That's all. Red flags, danger signs presence means admit the child, give ampicillin and gentamicin. Okay? I think you are all comfortable with the first question. Let's go to the next question. Let's go to the next question. So what is this? Look at the sound. The child is crying. Look at this. The child is crying and I could hear some sound. So what is that sound? The child is crying and I could hear some sound. So what is the typical clinical picture that you have right now? Right now you have, look at this. Right now you have a child with 6 months old, low grade fever, metallic cough and noisy breathing. So what is this actually? I repeat again, look at this. Look at this. You could see here some biphasic on and off stridor. Metallic cough. The child had preceding metallic cough. So what is this actually? Whenever you have any child, particularly a toddler or an young infant, presenting with 2 days of coryza, 2 days of metallic cough, and 2 days and presenting with a noisy breathing, with a metallic cough or otherwise known as barking cough, and if you hear biphasic stridor, it is ALTB unless otherwise proved. So what is the diagnosis? Acute laryngotracheobronchitis. Acute laryngotracheobronchitis, and it is caused by, people used to say para-influenza, but almost all viruses can cause this ALTB, right? ALTB. So what is the drug of choice? The drug of choice is steroids. What is the drug of choice? The drug of choice is steroids. Either it can be a nebulized budesonide or IM dexamethasone, IV dexamethasone, or oral prednisolone. Anything is fine, but you need to give a single dose of steroid. If it is severe and presenting with stridor at rest along with hypoxia, then you need to consider along with the steroids, you need to give, along with the steroids you need to give what? You need to give adrenaline. You need to give adrenaline nebulization. You need to give adrenaline nebulization. So based on this, let's have some other points with respect to noisy breathing in the child. So you can have stutter, which is a noisy breathing which arises due to presence of nasal secretion that occurs in acute viral coryza. The second noisy breathing. So what is this? This is called snoring. This is called snoring, which occurs due to pathology in nasopharynx due to adenoid. Adenoid. The third one is, what is this? This is called stridor. This is called stridor. Stridor occurs as a result of the most common cause is laryngomalacia, which usually resolves on its own. Laryngomalacia. When you have both inspiratory and expiratory component, so when you have both inspiratory and expiratory component, that is called biphasic stridor. Biphasic means both inspiratory and expiratory component. The pathology is in subglottis. There are two conditions that can cause. One is ALTB. Another is congenital or post-intubation subglottic stenosis. And finally, there are two expiratory sounds. The first three, stutter, snoring, stridor, are inspiratory, whereas biphasic is both inspiratory and expiratory, which can occur due to ALTB. And finally, when you have expiratory sounds, two expiratory sounds you can have. One is bronchi or wheeze, which occurs as a result of asthma. So expiratory, when it arises from bronchial constriction, it is usually wheeze. And again you have two types of wheeze. Wheeze is divided into two types. One is monophonic wheeze. Another is polyphonic wheeze. Monophonic wheeze means wherever you keep your stethoscope, that will be a uniform pitch. Same sound. Monophonic wheeze suggests foreign body inhalation, whereas polyphonic, different pitches of wheeze in different location is called as polyphonic wheeze, that is typical of asthma. And finally, when you have a sound in a sick child, expiratory, which occurs as a result of pneumonia, it is called grunting. So stutter, snoring, stridor are inspiratory. A biphasic stridor in ALTB subglottic stenosis is biphasic, whereas grunting in a sick child is expiratory, arising from the parenchymal pathology, and the wheeze, which arises as a result of either foreign body or bronchial constriction in a child with the wheeze. Okay, right. So this is with respect to our second concept. So first is over, second is over. Now let's go to the third one. Yes, I have different types of CT scans which show certain pictures, and based on this CT scan, let me show you one more video, you can call it as video. What is this? 2-year-old not able to walk, preterm baby. I repeat, 2-year-old not able to walk, preterm baby. Look at this. What is this? What is this? So let me come to the third question afterwards. What is this? 2-year-old not able to walk preterm. And you look at this, the legs are having adductor spasm. So this is called spastic CP. This is called spastic cerebral palsy. This spastic cerebral palsy usually occurs in children with preterm due to periventricular leukomalacia, and the child used to, because of the spasm of the both adductor, the child used to have commando crawling. growling. So this scissoring gait, spastic cerebral palsy occurs in preterm, and the underlying CT scan finding is periventricular leukomalacia, and this is called commando crawl, when the child is able to drag the entire lower limb and abdomen with the help of the normal relatively spared upper limb. So spastic, this is called spastic diplegia. What is this? This is called spastic diplegia. What do you mean by spastic diplegia? When you have increased spasm, you all know that cerebral palsy usually occurs in children with birth asphyxia. So this spasm can involve both upper and lower limb. When you have preferential involvement of lower limb spasm more compared to upper limb, that is lower limb spasticity is more compared to upper limb, this is called a spastic diplegia. Two things that you need to know. What you see in this picture is scissoring gait. In this picture is scissoring gait, and what is that crawl called as? That is called as commando crawling. Right. One more condition that can mimic this spastic diplegia is an inborn errors of metabolism. Particularly if a term comes with diplegia, preterm spastic diplegia is common. But when you have a term coming with the spastic diplegia, it is an urea cycle disorder. I repeat, it is an urea cycle disorder, and it occurs in arginase deficiency. You would have read in your biochemistry, it is called as, it occurs in arginase deficiency. But level 1 MCQ is, whenever you see scissoring gait, spastic diplegia, periventricular leukomalacia, preterm is the rule. Okay? Now I have, so this is question number 4. Now coming back to question number 3, I had shown you 4 photos, 4 CT scan in children with, I repeat, cerebral palsy. I repeat, these are all the CT images of children suffered with the birth asphyxia or cerebral palsy. So what is this? Yes, and it is very easy to have a pattern recognition. Okay, this is what we are going to see right now. So what is that pattern recognition? Here look at this, there is white matter hyperintensities around the periventricular area. Just now we have seen. So what is this? So this is called as periventricular Leukomalacia usually occurs in preterm. Birth asphyxia in preterm is different from term. In preterm, it preferentially involves periventricular area, whereas in term, it involves parasagittal and cortical areas. In preterm, periventricular and subcortical areas are involved. Subcortical areas are involved. Okay, so this is periventricular leukomalacia, suggestive of spastic diplegia occurring in a preterm. Now look at this. Look at this. What is this? One piece of dead tissue. Look at this. One piece of dead tissue in the brain. One piece of dead tissue in the brain. That dead tissue has been replaced by fluid. So what is this? Single piece of dead tissue in a child suffered from birth asphyxia. So this is called porencephaly. What is this? This is called porencephaly, which usually occurs as a result of stroke. And it usually produces hemiplegia. Hemiplegic CP. What is that CP? Hemiplegic CP. Whereas in preterm, it is diplegic CP. Diplegic cerebral palsy. Porencephaly occurs in hemiplegic cerebral palsy. In these two conditions, the tone is increased. Now, what is this? Multiple areas of brain are having numerous cysts, and this is called cystic encephalomalacia. This is called cystic encephalomalacia, suggestive of severe birth asphyxia, and the pattern here, the spasm will involve the entire upper and lower limb, and this is called spastic quadriplegia. This is called spastic quadriplegia. This is called as what? Spastic quadriplegia. This is called cystic encephalomalacia. So as I told you already, when you have a diplegic CP with preferential involvement of lower limbs, the underlying CT is periventricular leukomalacia. When you have a hemiplegic CP with increased spasticity, then it is called porencephaly, which can occur as a descent of stroke. Third, spastic quadriplegia. In CT, in cerebral palsy, you will find cystic encephalomalacia. And finally, these things are hypertonic, spastic, and but for as far as this CT is concerned, this is hypotonic, not hypertonic. This is hypotonic. And here there are involuntary movements. Here there are involuntary movements, because your voluntary movements are under the control of basal ganglia. Here there is basal ganglia hyperintense signals. So what you see here, you see basal ganglia hyperintense signal. Intense signal. So can you tell me in which condition you will get this involuntary movements? Vertical gaze palsy, sensory neural deafness. Can anyone tell me what is this? In which condition you will get this? Involvement of bilateral basal ganglia. So this is atonic cerebral palsy, which occurs as a result of Kern icterus, okay, which you all know that the basal ganglia is destroyed by increased indirect bilirubin, right? So we had discussed about noisy breathing, pneumonia, spastic diplegia image, and various CTs in various cerebral palsies. So 4 questions are over. Now another set of questions I have, and this concept, question number 4 concept is, I am not going to tell you, you tell me. Question number 4 concept is what? I have given you 4 kinds of, okay, I had given you 4 images. What are all the 4 images you have? So let me give you a case scenario for each and every one. You tell me the diagnosis then. Okay, right. Question number 1. So what is this? You see, so the concept, let me tell you for the first one. So this is a preterm. The child has got sensory neural deafness. The child has got sensory neural deafness. And the child is having microcephaly. Mother was having fever in first trimester. The child, let me tell you, having chorioretinitis. Now tell me what is the image finding for the first one. The image finding for the first one is periventricular calcification in CT. So what is this? This is periventricular calcification. Can you tell me in which infection you will get this periventricular calcification? It occurs in cytomegalovirus. So the first image is cytomegalovirus. The spotter is periventricular calcification that can be picked up in CT. Now, the second, you could see numerous, look at this. So, and one more finding, what is this? You could see numerous calcifications everywhere, not periventricular. This is diffuse calcification. This is diffuse calcification. Can you tell me in which condition? Diffuse, along with that, I will tell you CCC. What is that? Along with that, I can say chorioretinitis, hydrocephalus. So, in which condition you will, please tell me in which condition you will get this diffuse calcification with respect to an infection that happened in the first trimester. Can anyone tell me? Yes. Diffuse calcification, hydrocephalus, chorioretinitis. This triad occurs in congenital toxoplasmosis. Occurs in congenital toxoplasmosis, and this is also an image for congenital toxoplasmosis. So with respect to CT, with respect to congenital infection, two things can be asked. One is diffuse calcification for toxoplasmosis. The next one is periventricular calcification for cytomegalovirus. Now let me tell you one more thing. So what is the next thing I am going to tell you? Look at this. What is this? This is not torch infection. This is not torch infection. So this child has got, let me tell you the clue, intractable seizures. This child has got intractable seizures, and the child is having port wine stain in the eye. Along with that, the child having glaucoma. Can you tell me now? So what is the image finding and what is the diagnosis? Yes, you are correct. This is called railroad calcification. This is called railroad calcification. So what is the disease? Railroad calcification, intractable seizures, port wine stain, and glaucoma. What is this? This is nothing but, as you all know, Sturge-Weber syndrome. Is nothing but Sturge-Weber syndrome. Right? Good. So, diffuse calcification, periventricular calcification, intractable seizures along with the railroad calcification we had seen. Now, what is this? Let me tell you, but let me give you here. The next question we had come, image. What is this? Let me tell you, this is here 10-year-old child. So, the next question will be, what is this child? This is here. So, this is a 10-year-old girl. Fever 2 weeks. Weight loss for the past 3 months. And the child was having cough for the past 2 weeks. So, what is the answer? You tell me, my dear boys and girls, what is the answer? So it is, and the child is having, let me tell you, the child is having neck stiffness. The child is having, let me say, weakness of right upper limb and lower limb. So what is the diagnosis? You tell me. What is the diagnosis? You tell me. Look at this. The CT reveals this. Look at this. The CT reveals this. Your third ventricle is dilated. Your lateral ventricle is dilated. Your temporal arm of the lateral ventricle is dilated. And what is this condition? Whenever you have fever, subacute meningoencephalitis, hydrocephalus, and a weakness, cranial nerve palsy, you need to think in terms of dash. You need to think in terms of tuberculous meningitis. So what is this actually? This is actually a tuberculous meningitis. The diagnosis is tuberculous meningitis. So what is the clue, my dear boys and girls? The clue here is fever plus hydrocephalus is equal to tuberculous meningitis unless otherwise proved. Right now, so this is with respect to the image on the right side. What is that image on the left side? You have a ring enhancing lesion. This ring enhancing lesion, okay, has got perilesional edema. Look at this perilesional edema. Usually these cases will present with focal seizures. In a country like India, if a child is presenting with focal seizures, it can be due to two things. One is it can be neurocysticercosis. Or it can be tuberculoma. How to differentiate with respect to whether it is a case of tuberculoma or neurocysticercosis? The answer is very, 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 very simple. With the help of for your level, with the help of an MRS spectroscopy, not only with your MRS spectroscopy. Here in this case, the MRI spectroscopy had revealed a peak. What is this peak? This is called lipid peak. So this lipid peak is suggestive of tuberculoma. This lipid peak is suggestive of tuberculoma. So with respect to CT brain, my dear kids, periventricular calcification, CMV, diffuse calcification, cytomegalovirus, railroad calcification, Sturge-Weber syndrome, fever with ventricular dilatation, tuberculous meningitis, focal seizure with the lipid peak and perilesional edema is tuberculoma, which is often deep-seated and single, often. Whereas when it is superficial, not much perilesional edema, without any lipid peak, it is usually neurocysticercosis. For neurocysticercosis, a course of prednisolone and prednisolone for about a week and either 7 or 21 days of albendazole is fine. Whereas for tuberculoma, you need to give 1 year of ATT, 2 HRZE plus 10 HRE. Whether it is a tuberculoma or tuberculous meningitis, the duration of treatment is 1 year, 2 months of intensive phase and 10 months of continuation phase. Steroid is the rule in both tuberculous meningitis and tuberculoma for about 6 to 8 weeks. This is with respect to our concept 5. Now, what is that concept? Look at this child. So, okay. So, the concept 5 is over. Let's come to this next concept. What is... Oh, I'm sorry. Okay. Let it be an image then. One second. Let it be an image. Look at this. I was planning for a video, but this is a spotter. Look at the spotter. What is this actually, my dear boys and girls? What is this? Can anyone tell me what is this? Open to your wide thoughts. What is this? This is called, what is this? This is called disseminated molluscum contagiosum. This is called disseminated molluscum contagiosum. In which condition you will get this molluscum contagiosum. This is called disseminated molluscum contagiosum. In adults, you will say HIV, but in pediatrics, I will vote for hyper IgE syndrome. I will vote for hyper IgE syndrome. In that, you have two things. One is autosomal dominant, another is autosomal recessive. Autosomal dominant is STAT mutation, whereas autosomal recessive is DOC mutation. So this is suggestive of autosomal recessive DOC8 mutation, which leads to disseminated molluscum contagiosum. What? So I repeat, disseminated molluscum contagiosum in pediatrics is suggestive of hyper IgE syndrome. If you want to know further, autosomal dominant due to STAT mutation, whereas autosomal recessive due to DOC8 mutation. Multiple viral infections, herpes zoster, varicella, molluscum are more in favor of DOC8 autosomal hyper IgE syndrome. Right. Now, so based on this, let me track some of the simple clinical clues to consider an underlying inborn errors of metabolism. Recurrent pneumonia, otitis, sinusitis after 6 months. Yes, whenever you have recurrent pneumonia, otitis, I used to teach my students OPS. What is that? OPS. What do you mean by OPS? Otitis media, pneumonia, sinusitis after 6 months. Usually in favor of what? In favor of what? In favor of B cell deficiency. Particularly if it is a boy, what you will call it as Bruton's A gamma globulinemia. So this is suggestive of Bruton's A gamma globulinemia. Which one, my dear boys and girls? Recurrent pneumonia, sinusitis, otitis media after 6 months of age. Now, persistent pneumonia, diarrhea, large BCG scar, 3 months old. So large BCG scar means this child has been suffering from BCGosis, that is BCG induced TB, disseminated TB, and this is suggestive of severe combined immunodeficiency. Persistent pneumonia or diarrhea. Pneumonia can be due to cytomegalovirus or the BCG that is given by you or pneumocystis carinii pneumonia. Whereas diarrhea, which one? Pneumonia. Diarrhea can be due to cytomegalovirus. Diarrhea can be due to cryptosporidium. Diarrhea can be due to isospora. These are all opportunistic infections. So these opportunistic infections, diarrhea, usually in an adult it is a T cell defect, that is HIV. In pediatrics it is severe combined immunodeficiency. What is this? Transfusion associated reactions usually occurs in selective IgA deficiency. What is this? This usually occurs in selective IgA deficiency. Why is it so? The answer is very simple. When you don't have IgA, the body will automatically produce anti-IgA. So, for example, you are a person who doesn't have IgA, so invariably you will have an anti-IgA. So, what will happen whenever you need a blood transfusion, even though you belong to B blood group and your donor also belong to B blood group, but what will happen when the donor gives blood to you? The IgA present in the donor will be reacted by the anti-IgA that is present in your body, leading to transfusion reaction. This occurs in selective IgA deficiency. Recurrent abscess and lymphadenopathy is a feature of an NADPH oxidase deficiency. What is that? Very good. Chronic granulomatous disease. Recurrent abscess is a feature of chronic granulomatous disease. Disease, and they are prone for aspergillus, invasive aspergillus. They are prone for recurrent staph aureus infection. Then, what is this? Hypopigmentation, giant granules. Giant hypopigmentation means albinism. giant granules in the neutrophils. What does it mean? The first condition, that is the previous condition, recurrent abscess, chronic granular matters, is due to defective NADPH oxidative burst, whereas that hypopigmentation and the giant granules is due to defect in phagolysosome formation. Phagolysosome formation. This phagolysosome, defective phagolysosome formation occurs in, yes, giant granules, infection, albinism. This triad occurs in Chidiac-Higashi syndrome. Chidiac-Higashi syndrome. Okay, which one? Hypopigmentation, giant granules in the neutrophils. And finally, a non-healing ulcer with a total count of 50,000 and your with a total count of 50,000 and your neutrophil is around 90. Don't think that it is leukemioid reaction. A non-healing painless, a non-healing pustless ulcer along with a very sky high absolute neutrophil count is suggestive of leukocyte addition defect. Is suggestive of leukocyte addition defect. Is suggestive of leukocyte addition defect. So the first, leukocyte addition absent, means leukocyte addition defect, painless ulcer. The second point, absent phagolysosome formation, is Chidiac-Higashi disease. The third point, when you don't have NADPH oxidative burst, it leads to chronic granulomatous disease. The investigation for chronic granulomatous disease is NBT, nitroblue tetrazolium test, which is the screening test of choice. Okay, look at this. What is this? As I told you already in my previous discussion, look at this. Giant granules in the neutrophils. This giant granules in neutrophils is suggestive of what? Giant granules in neutrophil is suggestive of what? Is suggestive of Chidiac-Higashi syndrome. Now, the next question. What is this? Abnormal faces. That abnormal was missed. Abnormal faces. Painless abscess. Retained teeth. Eosinophilia. What I used to teach my child. FATED. So what is this? FATED. Abnormal faces. Second one is painless abscess is Job syndrome. So what is this? Painless abscess, Job syndrome, retained teeth. Okay, atopic dermatitis. Again, all these in favor of autosomal dominant hyper IgE syndrome. Autosomal dominant hyper IgE syndrome due to STAT mutation. As I told you, where you will get this disseminated molluscum contagiosum. This disseminated molluscum contagiosum usually occurs in, okay, DOCK8 mutation. DOCK8 mutation, right? Okay, what is this? Microthrombocytopenia. The next question, microthrombocytopenia. Eczema infection, you all know. A child with recurrent infection, persistent eczematous dermatitis. Persistent eczematous dermatitis. And what is this? Eczematous dermatitis and small minimal number of platelets is, yes, very good. Wiskott-Aldrich syndrome. When a child with atoxic gait, bronchiectasis, and you could see some dilated blood vessels in the ear lobule, in the conjunctiva, in the nose tip, with reduced alpha fetoprotein, Sorry, increased alpha fetoprotein and reduced IgA is ataxia telangiectasia. Telangiectasia. Okay. So what is this? The child is prone for pneumocystis carinii pneumonia, and among that immuno IgM is normal or high, whereas other immunoglobulins low. So what is this condition? Other immunoglobulins low. This is called hyper IgM syndrome. And finally, the last one in inborn errors of metabolism or primary immunodeficiencies. Whenever you have a child with recurrent typhoid or recurrent TB, it is Mendelian susceptibility to mycobacterial diseases. So what is this actually? Normally your T0, that is pluripotent T cells, will be converted into Th1. This Th1 in turn produces interferon gamma, and this interferon gamma will attract macrophage, and this macrophage will in turn produce a tumor necrosis factor alpha and kills your TB and typhoid. Whenever you have some issues with respect to Th1, which is usually the T0 will Th1 or interferon gamma, your TB bacilli will not be killed. Your TB bacilli will not be killed. And this is called as Mendelian susceptibility to mycobacterial diseases due to absence of interleukin 12. That is the one which converts your T0 to Th1, and absence of interferon gamma. So this concept, the last and previous concept, is based on immunodeficiency. So you can have giant granules, you can have microthrombocytopenia with infection, you can have disseminated molluscum contagiosum. Right. Now, yes, I have next. Okay. Now I have three case scenarios in which neonatal respiratory distress I am going to deal with. Neonatal respiratory distress. Can you come up with your answers? Neonatal respiratory distress. So, what is this? First child. Let me tell you the scenario right now. First child. So, what is that first child? The first child having respiratory distress from day one. Frothing from mouth. This is first case. The second child is again respiratory distress from birth. Air entry reduced on left hemithorax. The third child. What is that? The third child. The child respiratory distress from birth, and you have scaphoid abdomen. Respiratory scaphoid abdomen. So what is that? Can you tell me what is the answer? Respiratory distress since birth, scaphoid abdomen, and you hear gurgling sound. Okay, you hear gurgling sound in chest. So now you tell me the answer, my dear boys and girls. The first one. Okay, what is the first one? The first one you could see coiling of NG tube. So this is tracheoesophageal fistula. Newborn respiratory distress, look for coiling of NG tube. The second case, there is emphysematous lung on the left side and mediastinum is pushed to the right side, and there is collapsed lung on the left lower hemithorax. What is this? This is not pneumothorax because you could see vascular markings. This is congenital. Often asked question, congenital lobar emphysema. Congenital lobar emphysema. Right? Congenital lobar emphysema. Right. Then next, what is this? Instead, the mediastinum heart is shifted to the left. There is diaphragm border on the left side, but the liver is pushed up on the right side. And the border of diaphragm is here. So what is this? Very good. This is a case of congenital diaphragmatic hernia. Congenital diaphragmatic hernia. So newborn with respiratory distress with frothing, look for coiling of NG tube. With a tachypnea and reduced breathing, look for emphysematous left upper lobe. With scaphoid abdomen, respiratory distress and gurgling sounds in the chest, you need to look for congenital diaphragmatic hernia. Congenital diaphragmatic hernia. So this concept is over. Right, the next concept. Let us go for the next concept. This is mainly for congenital heart diseases. So what is this? Here I have a massive cardiomegaly. I have a massive cardiomegaly. What is this? Here I have a egg-on-side heart. Egg-on-side heart. Here I have reduced pulmonary blood flow because I could see the lung properly. And there is no cardiomegaly. There is no cardiomegaly. And you have tilted apex. Tilted upturned apex. You have upturned apex. Upturned apex and the child is cyanotic. Okay, and finally, I have figure of 8 appearance. 8 appearance, I have cyanosis, I have congestive cardiac failure, and I have ASD murmur. And I have ASD murmur. Okay, what is this massive cardiomegaly? This massive cardiomegaly plus cyanosis occurs in which condition? Can you tell me? Occurs in which condition? Massive cardiomegaly. Cyanosis occurs in which condition? Epstein's anomaly. Epstein's anomaly. What is this? This child, Egon side. But before that, you need to know sudden cyanosis. Day 3 after birth. No murmur. And the X-ray, oh, she's showing Egon side. Yes, what is this? This is called transposition of great arteries. This is called as transposition of great arteries. Finally, when you have a no cardiomegaly, pulmonary oligemia, cyanosis, upturned effect, this is called boot-shaped heart. Suggestive of what? Tetralogy of Fallot. Finally, when you have a combined triad of cyanosis plus CCF plus ASD murmur. What is ASD murmur? Fixed S2 split along with the figure of 8 is called as supra cardiac total anomalous pulmonary venous connection. Supra cardiac total anomalous pulmonary venous connection. Okay, right. Anomalous pulmonary venous connection. Okay. So these are all the X-rays that can be potentially asked in your entrance examination. Right. Now, beautiful X-rays. Beautiful X-rays. So let me tell you, let me show you some of the videos. What is this? Let me give you a picture. Sudden onset cough. This child, sudden onset cough. Sudden onset cough. Look at this. There is increased aeration on left side, along with that reduced air entry. And the child is a toddler. What is this? Whenever you see one lung is hyperinflated, but reduced air entry, this is called obstructive emphysema. This is called obstructive emphysema, suggestive of foreign body aspiration in left main bronchus. This X-ray. What is this X-ray meant for? Look at this X-ray. Okay, the lung is totally collapsed. I could see the collapsed lung. There is no airway, there is no vessel marking at all. There is no vessel marking at all. There is no vessel marking. Collapsed lung. What is this? No airway markings. Collapsed lung is pneumothorax. This is called pneumothorax. Collapsed lung along with no vessel markings. Here also the lung is more black. More black. And finally, the third scenario. What is the third scenario? Look at this. The child is having fever, cough, breathlessness, weight loss. Let me give you a clue. But CBC showed an absolute eosinophil of 2000 cells per cubic millimeter. What is the diagnosis? What is the diagnosis? Look at this. What is this? Look at this. What is the cyst? This is nothing but hydatid. This is nothing but hydatid cyst. So unilateral hyperinflation with reduced air entry but vascular markings present foreign body. Unilateral hyperinflation with very much collapsed lung, absent air entry and absent vessel markings, pneumothorax. And this is, what is that? Hydatid cyst. These are all our own X-rays. Okay. Now, let me come up with one more set of X-rays. One more set of X-rays. This one was covered. I am not going to discuss in detail. This one was covered. So what is this? So what is the scenario you can expect for this one? Let me tell you. Fever 2 weeks. Cough 2 weeks along with weight loss. So what is the diagnosis? You could see numerous cavities. So cavity, hilar adenopathy, miliary mottling are suggestive of tuberculosis. What is the next investigation of choice? Sputum, TB, NAT. Okay, now let's come to the next one. What is this? Spotter, you tell me. The answer is there. Let me tell you. The child is having wet cough since birth. Since birth. The child is having deafness. Persistent rhinorrhea the child is having. And the child is having persistent sinusitis. And what is this on the X-ray? Look at this. Liver is on the right side. Apex is on the, liver is on the left side. Apex is on the right side. What is this called as? Situs inversus totalis. What is the disease you mean with Cartaginer syndrome or otherwise primary ciliary dyskinesia? Cartaginer syndrome. or otherwise primary ciliary dyskinesia. Okay, right. And the last, what is this child is suffering from? Upper lobe bronchiectasis. What is the child suffering from? Upper lobe bronchiectasis. So let me tell you. So so this is, I'm taking it out. So what is this? So when a child is having upper lobe bronchiectasis, oily stools, what is the diagnosis? Yes, the child is having cystic fibrosis due to, there are so many mutations, but for my kids delta F5 not mutation. What is the investigation of choice? A sweat chloride of more than 60 millimole per liter. So cystic fibrosis, they are more prone for pseudomonas and more prone for Burkholderia cepaceae. More prone for Burkholderia cepaceae. Right? So upper lobe cavity TB, wet cough, dextrocardia, primary ciliary dyskinesia or Cartagena syndrome. Upper lobe bronchiectasis with oily stools, cystic fibrosis. Okay? Right. What is this? I received this case last Tuesday. What is this case? What is this case? Let me say this is a 10-month child with the hemoglobin of 6 gram, platelet of 60,000 with hepatosplenomegaly, no fever. What is the diagnosis? What is the diagnosis? Can you tell me? What is the diagnosis? The diagnosis is osteopetrosis. The diagnosis, look at this, bone within bone. Look at this. There is no medulla at all. They don't think it is rickets. It is not rickets. There is no medulla at all. So this is bone within bone. This is bone within bone. What is this? This is osteopetrosis due to defect in osteoclast. Due to defect in osteoclast. What is the treatment of choice? Bone marrow transplant. Why? Because osteoclasts are developing from macrophages. Macrophages are produced in bone marrow. So, when you have a bicytopenia or pancytopenia, along with the bone within bone appearance, it is osteopetrosis. Right? Okay. Next question. What is this? What is this? Now you can say, what is this? Now I could say, what is this? I could say cupping. I could say fraying. I could say widening of epiphysis. So this cupping, fraying, widening, you all know it occurs in rickets. You all know it occurs in rickets. Okay, cupping, fraying, widening. The investigation of choice for nutritional rickets is 25 OHD3 less than 12 nanogram per deciliter is deficiency, whereas 12 to 20 nanogram per deciliter is insufficiency. Is insufficiency. Okay, 12 to 20 nanogram is insufficiency, right? So this is after treatment. This is after treatment. So what is the treatment? 60,000 international units per week. of vitamin D. Vitamin D for 8 weeks to 12 weeks. Or you can give infants 2000 international units per day into 8 to 12 weeks. Post infants 3000 international units per day into 8 to 12 weeks. After 4 weeks of vitamin D, you will look at this line is lucent pre-treatment, this line is calcified post-treatment. And what is this called as? This is called as zone of provisional calcification. These are all true cases, my dear boys and girls. This is called zone of provisional calcification. This is zone of provision. You won't see this kind of true x-rays elsewhere. Not Google downloaded images. Zone of provisional calcification. Look at this zone of provisional calcification. Look at this. Look at this. This zone of provisional calcification is suggestive of nutritional rickets. Okay? Right. So vitamin D. Zone of provisional calcification. Apart from that, features of vitamin D deficiency in bones. Vitamin D deficiency in bones. What he is suffering from? What he is suffering from? Little bit hungry, I'm sorry. So what is this? Periorbital puffiness. This is periorbital puffiness. Okay. This is so this is periorbital puffiness. What does it suggest? With reduced urine output, with genital edema, with a reduced serum albumin of less than 3 grams or 2.5 grams per liter, spot PCR more than 2, serum cholesterol more than 200 milligram per deciliter. What is this? Periorbital puffiness, genital edema, ascites is a feature of nephrotic syndrome. Nephrotic syndrome. In nephrotic syndrome, there is no hematuria, there is no hypertension. Whenever you have hematuria and hypertension, it is more in favor of post-streptococcal glomerulonephritis. Hematuria or hypertension is a feature of post-streptococcal glomerulonephritis. Right. So this is about nephrotic syndrome. What is this? Again. So this is okay. Over. Next, look at this. Umbilical hernia. Look at this. Ascites. Look at this genital edema. Again, this child is also having umbilical hernia. Look at this. The child is having genital edema. The child is having ascites. But the child looks very, 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 very young. So this is called congenital nephrotic syndrome. When you will say when the onset is less than 3 months, when the onset is less than 3 months, you say congenital nephrotic syndrome. 3 months. Treatment, none. Only renal transplant. Only renal transplant. Okay, this is congenital renal transplant. Okay. What else? Okay, renal transplant. Okay, what else you need to know? There is no treatment. Most common cause is what is the most common cause? The most common cause is nephrin gene mutation, nephrin podosin as well as laminin. Second most common cause, torch infection. That's it, congenital nephrotic syndrome. Now, let me show you a beautiful video. Tell me what is the diagnosis. I'm not supposed to say beautiful video. What is this? Deep breathing. What is this? The child is having deep breathing. No retractions as such. No retractions as such. Let me tell you, the child has lost weight in the past 1 week. There is no fever, no cough. And what is this breathing? This breathing is called as small breathing or asymptotic breathing. Okay, deep breathing without any retractions and tachypnea is Kussmaul breathing, which is well supported by, which is well, look at the bicarbonate. The bicarbonate is just 5. So severe metabolic acidosis. Severe metabolic acidosis. Okay. Severe, and look at the pH. pH is very, very low. Normal is less than 7.35 to 45. Here is just 6.9. Severe metabolic acidosis. Severe metabolic acidosis. So what is this condition? Metabolic or Kussmaul breathing. The most common condition in pediatric age group is diabetic ketoacidosis. So this photo shows you Kussmaul breathing. What is this? What is this? What is this? So this is knuckle hyperpigmentation. Suggestive of what? B12 deficiency. What is the clue for B12 deficiency? MCV will be more than 100. RDW, red cell distribution, with more than 15. What is the investigation of choice? You can say serum B12 less than 170 picograms per ml. 170 picograms per ml. Or what is the screening test? What is the screening test? The screening test is increased methyl malonic acid. I repeat, increased methyl malonic acid. That chilling bullying test and all gone. Why? Because methyl-malonyl-CoA is converted into succinyl-CoA by B12. When the B12 is absent, methyl-malonic acid will be increased. Apart from that, it can also lead to pancytopenia. It can also lead to increased LDH. Which one? B12 deficiency. And it can also lead to infantile tremor syndrome. Can also lead to infantile tremor syndrome. And what is this? Knuckle hyperpigmentation, suggestive of B12 deficiency. Knuckle hyperpigmentation, suggestive of B12 deficiency. Right. Now, what is this? Look at this, coarse facial features, thick lips, coarse facial features. What is this? Mucopolysaccharidosis. What are all the mucopolysaccharidosis you don't know? Okay. Is it possible to decode the different types of mucopolysaccharidosis? The answer is yes. When you have mental retardation, corneal opacity, coarse facial features, minimal skeletal involvement with hepatosplenomegaly, this is a case of typical Hurler syndrome. Hurler. When you have mental retardation, but okay, corneal opacity, none. Coarse facial features, yes. Dysostosis multiplex skeletal dysplasia, yes. Organomegaly, minimal, not much, minimal. The absence of corneal opacity is Hunter. Whereas when you have only severe mental retardation without other features, it is called as Sanfilippo. It is called Sanfilippo. It is called as Sanfilippo. Whereas when there are no mental retardation, no coarse facial features, no organomegaly, but severe skeletal involvement means either it can be Marquio or it can be Morotier-Lamy. That's all. This is how you need to decode different mucopolysaccharidosis. Right. Next. Look at this. What is happening to the child? Look at this. The heart rate is 262. Narrow QRS complex. Heart rate 262. Narrow QRS complex. Absent P waves. Real scenarios. Absent P waves. Oh, what is happening now? Look at this. Look at this. What is happening? What is happening? The rate is gradually decreasing. The rate has become 100. I could see QAP presence of P waves. Yes. What is this? This is a case of supra. I'm sorry. This is a case of what? This is a case of supraventricular tachycardia. Then you need to consider when heart rate is more than 220 per minute, narrow QRS complex of less than 0.12 second, absent P waves is supraventricular tachycardia. Drug of choice, adenosine. Drug of choice, adenosine. How to, so that is how to suppress? You can give beta blocker. That is propranolol. Okay, or digoxin. But when you have WPW syndrome plus supraventricular tachycardia, avoid digoxin. Avoid digoxin. You can give beta blocker, that is propranolol. That is propranolol. So this is supraventricular tachycardia. Let's come to the milestones. Okay, you need to know, no? Social smile usually by 2 months. Recognizes mother 3 months. Stranger anxiety 6 months. Waves by 9 months. Understand simple questions 1 year. Points to objects which is interested 15 months. Domestic mimicry, whatever you do, the child mimics 18 months. Name two objects, two body parts, five familiar objects. If the child can ask food, it I want food, drink, etc. Pulls people to show toys. 2 years. Full name begins to count, two colors, simple rhythms, simple rhymes, share toys. 3 years. Left right discrimination, goes to toilet alone, cooperative play. 4 years. Follow three-step commands, four colors, repeat four digits. 5 years. 5 years. Okay? Right. Then, so this is with respect to key social and adaptive milestones. Now, key language alerts to sound 1 month itself. Cooing 2 months. Laugh loudly 3 months. Monosyllable ma pa ta by about 6 months. Bisyllable by about 9 months. One or two words with meaning 1 year. 8 to 10 words with good vocabulary by about 18 months. I, me, you usually occurs by true speech 2 years. As you all know, full name, J, gender 3 years. Ask meaning of word 5 years. Tell recent experiences 4 years. Tell recent experiences 4 years. Again, block skills. 15 months, 2 blocks. 18 months, 3 blocks. 6 years, by about 2 years, 6 blocks. 2.5 years, 6 blocks with the chimney. 3 years, 9 blocks. 4 years, cross. 5 years, triangle. 12 years, 6 years, pyramid. 9 years, okay, and 9 years, okay, and 12 years. 12 years, cylinder. 9 years, cube. These are all the milestones with respect to blocks, with respect to drawing skills and this one. Okay, right. Okay, I'm sorry. So this one is okay. So 9 years and 12 years with respect to drawing figure, cylinder and cube, right? So what is this? What is this picture meant for? Turning diagonally back. Diagonally back. This is called pivot. This is called pivot by about 9 months. Sitting without support. This is sitting without support 8 months. Sitting with support support 6 months. Whereas standing alone by about 1 year. Standing alone by about 1 year. Right, with respect to milestones. Okay, what is this? Some of the things that you need to know with respect to neonatal resuscitation. With respect to neonatal resuscitation. So what is this? This is called sniffing position. Roll of towel under a shoulder blade is called sniffing position. What is this? This is called CPAP. When you will use CPAP, heart rate more than 100 per minute, persistent cyanosis, labored breathing. Labored breathing. Labored breathing. This is called as what? CPAP. Sniffing question. What is this? This is called laryngeal mask airway. Particularly useful when you resuscitate. When you resuscitate, but you don't know how to intubate. And what is this? This is called chest compression. This is called chest compression. And this is two thumb technique. This is two thumb technique. So what are all the other things that they will ask you? Positive pressure ventilation can be given if the heart rate is less than 100 per minute, 1 minute after birth. When you will give chest compression, when the heart rate is less than 60 per minute. When you will give adrenaline, what is the dose of adrenaline? It is fixed right now, 0.2 ml. Or otherwise 0.2 ml per kg of 1 in 10,000 adrenaline. For 1 in 10,000 adrenaline. For ET tube, it is 0.5 ml of adrenaline. Okay, for umbilical vein adrenaline, 0.2 ml per kg of 1 in 10,000. Along with that, 3 ml saline flush. 3 ml saline flush. Neonatal resuscitation. What do you mean by delayed cord clamping? Cord clamping 30 seconds to 1 minute after birth is called as delayed cord clamping. Okay, right. There is no role for RL in neonatal resuscitation. We use either normal saline. We use normal saline. We use normal saline or O negative blood. We don't use RL right now because it can potentiate the underlying lactic acidosis. Next, what is this? RBC is low. Next question. RBC is low. Hemoglobin is low. Hematocrit is low. MCV is 52. RDW is 20. What is this anemia? So RBC low. Hemoglobin low. Hematocrit is low. So there is proportionate decrease. There is proportionate decrease of all three along with MCV less than 70 femtoliter and RDW more than 15. Diagnosis, it is iron deficiency anemia. What is this? This is iron deficiency anemia. How to differentiate between thal? That is thal minor or intermedia. Very simple. How to differentiate between thalassemia? The answer is MCV in thal will be low. RDW will be normal. Remember, RBC number will be normal, unlike iron deficiency anemia. That's it. Okay, but disease in this case is thalassemia this is iron deficiency anemia. Next, what is this case? What is this case? The next question, what is this case? So look at this, hemoglobin is low. So I have a case in which hemoglobin is and my platelet is also low. Platelet is also. Look at this. MCV is 104. MCV is 104. Look at this RDW. RDW. Red cell distribution width is more than 15. RDW increased only in cases of nutritional anemia. Here RDW is increased, but it is macrocytic. So macrocytic megaloblastic anemia with raised RDW is B12 deficiency. Is B12 deficiency. Okay, right. B12 deficiency. Okay. Again, a rapid revision on certain things with respect to IM. Thiamine, where you will use. Thiamine is used in maple syrup urine disease. Riboflavin is used in mitochondrial disorders. Biotin is used in multiple carboxylase deficiency. Pyridoxine is used in homocystinuria. B12 is used in methylmalonic aciduria. Sodium benzoate, sodium phenylacetate, L-arginine is used in urea cycle disorders. L-carnitine, where you will use organic aciduria. Metronidazole, again organic aciduria, particularly propionic aciduria. Nitisinone, where you will use nitisinone. Nitisinone is used in tyrosinemia as well as in alkaptonuria. Miglustat, substrate reduction therapy, is used in Gaucher's. Lorenzo oil is used in Gaucher's. This one is Gaucher's disease. Lorenzo oil is used in X-linked adrenoleukodystrophy. Vitamin C, again used in homocystinuria as an antioxidant as well as in alkaptonuria. Very, 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 very important. You will get at least one question from this simple single PPT. Okay, then you must be given a case of respiratory distress in a newborn, and you might be asked to calculate the Downey score. How to calculate Downey score? Respiratory rate less than 60 per minute, given a score of 0, 60 to 80, given a score of 1, and score of 2 is more than 80. This is with respect to respiratory. You will be definitely giving a picture of respiratory distress and you will be asked to calculate the Downey score. Cyanosis. No cyanosis. Cyanosis disappears with 40% oxygen. Cyanosis not disappearing with 40% oxygen. Okay, no persist despite 40% oxygen. Then retractions, no retractions, mild retractions, moderate to severe retractions, score 0, 1, 2. Grunting, no grunting, mild grunting, severe grunting. Without stethoscope you can hear. Without stethoscope you can hear. That is severe grunting. Air entry. Okay, right. Air entry, normal air entry, reduced air entry, absent air entry. This is with respect to Downey's score. Right. What is this? What is this? Okay. The first one is head circumference. Head circumference is otherwise known as occipitofrontal circumference. Usually measured above, you need to keep your inch tape above orbital ridge. Posteriorly, you need to keep over occipital protuberance. Normal is 33 to 35 centimeter at birth. Then 2 centimeter per month in the first 3 months. 1 centimeter per month from 3 to 6 months. 0.5 centimeter per month from 6 months to 1 year. 0.25 centimeter per month from 1 to 2 years. Okay, right. This is with respect to head circumference. And what is this? This is called stadiometer. To measure the height of the child more than 2 years. Less than 2 years, you use infantometer. Less than 2 years, you use infantometer. More than 2 years, stadiometer. Height, you measure height. Less than 2 years, length. Okay. Normal height is 50 centimeter at birth, 75 centimeter at 1 year, 87 centimeter at 87 centimeter at 2 years, roughly 100 centimeter at 4 years. Very important, from 4 years to 12 years or from 6 years to 12 years, you should gain a maximum of 4 centimeter per year, minimum of 4 centimeter per year. When you gain less than 4 centimeter per year, it is growth hormone deficiency or thyroid hormone deficiency. Okay, thyroid hormone deficient. Now, what is this? Chest circumference. You need to measure in mid inspiration at the level of the nipple. At the level of the nipple. Normal chest circumference is how much? At birth, head circumference is more than chest circumference by 3 centimeter. By about 1 year of age, head circumference equal to chest circumference. After 1 year, chest circumference will be more than head circumference. Okay, head circumference. Then, what is this? Mid upper arm circumference. Upper point is tip of acromion. Lower point is tip of olecranon. Tip of olecranon. So midpoint, if it is in the midpoint, you need to take more than 12.5 centimeter normal, less than 11.5 centimeter SAM, 11.5 to 12.5 centimeter moderate acute malnutrition. Okay, right. Okay, what is this question? What is this child? What is this child? Look at this child. Look at this child. What is suffering from? Look at this child. What is suffering from? What is suffering from? This is called Gower sign. This is called Gower sign. Usually established at 6 years. Boy with Gower sign is suggestive of Duchenne muscular dystrophy. Is suggestive of what? Duchenne muscular dystrophy. Okay, Duchenne muscular dystrophy. CPK will be more than, usually is less than 150. Usually it will be in thousands. It will be in thousands. It is due to deletion of dystrophin gene. So any child with the Gower sign is, boy particularly, is usually Duchenne muscular dystrophy unless otherwise proved. Otherwise proved. What are all the treatment? Steroids, you know, prednisolone, deflazacort, but that steroid without any steroidal side effect is, what is that? Steroidal side effect is, what is that? Vamorolone. What is that? Vamorolone. Second, exon skipping agents are etiplursin. Exon skipping agents are etiplursin. Stop codon drugs used in this disease is called as ataluren. Okay, just I want you to sensitize because DMD is such an important question. You will be asked these rarities. Okay, right. What is this? Child is totally floppy. What is this? Child is totally floppy. And the child is oxygen dependent. So what is this called as? This is spinal muscular atrophy. What is this? This is spinal muscular atrophy. It is an anterior hornset disease. The clue is tongue fasciculation. The clue is tongue fasciculations and absent deep tendon reflexes. Absent deep tendon reflexes. Remember, very important. There are so many new drugs had come for spinal muscular atrophy. What are all those drugs? Look at this. Okay, Zolgensma, an IV gene therapy, whereas nusinersen, an antisense oligonucleotide giving intrathecal. Okay, Risdiplam, oral drug is used as an mRNA splicing agent. Very important. Floppy infant is a damn sure question for you. Most for your level, it is spinal muscular atrophy, otherwise proved. It is nothing but a pediatric component of amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis or motor neuron disease is acquired, but this is congenital. Okay, right. What is this? Look at this, my dear boys and girls. WBC is, what is this? WBC is somewhat around, what is this? In lakhs. WBC in lakhs. Thrombocytopenia is there, anemia is there, and in that lymphocytic is predominant. So when you have an bicytopenia, that is hemoglobin is low, platelet is low, but your absolute lymphocyte is sky high, along with hepatosplenomegaly, along with the lymphadenopathy, along with hepatosplenomegaly, along with the lymphadenopathy, with bone tenderness. What is the diagnosis? With the bone tenderness, what is the diagnosis? Very good. It is acute lymphatic leukemia. It is acute lymphatic leukemia. Bicytopenia with absolute elevation of lymphocytosis is acute lymphatic leukemia unless otherwise proved. Very important. Okay, then. So what is this? Knuckle hyperpigmentation, suggestive of B12 deficiency. Occipital encephalocele, suggestive of folic acid deficiency. And alopecia is suggestive of biotin deficiency. You people are often asked about only two things now. One is angular cheilitis, suggestive of riboflavin, and the photosensitive rash in sun exposed areas is pellagra. Along with that, you will know Bitot spot. But apart from this, know about this alopecia with the developmental delay, biotin deficiency. This is biotin. Folic acid deficiency leading to neural tube defect. And finally, hyperpigmented knuckle is B12 deficiency. Right? Next, what is this? Fever. Fever, what is this? Fever 2 weeks, cough 2 weeks. Weight loss 5% over a period of 3 months. What is this? This is nothing but hilar adenopathy. And what is this? This is nothing but miliary mottling. And this is a cavity. So do CB naught. When you see miliary mottling, do CB naught. When you see hilar adenopathy, do CB naught. What is this? This is pleural effusion. Okay. Pleural effusion not suggestive of TB. Okay, so here you can try antibiotics. Even though people say unilateral pleural slow onset diffusion is suggestive of TB, but as far as your entrance examination is concerned, a miliary mottling, hilar adenopathy and cavity only are suggestive of TB and you need to go for CB naught directly. Rest of the X-ray findings you need to choose. You need to choose antibiotic rather than CB naught because they are not TB specific X-rays. TB specific X-rays, take X-ray, take CB naught. Non-TB specific X-ray, try antibiotic. That's all. Okay, then what is this? What is this? Tongue sunken, skin pinch goes back very slowly. Look at this, skin pinch goes back very slowly. And it sunken eyes, what does it mean? It is a case of severe dehydration. What is the treatment? 100 ml per kg of oral or normal saline, 70 ml per kg and then 30 ml per kg. 30 ml per kg half an hour, 70 ml per kg next 2.5 hours because the child is more than 1 year. So this is again a great spotter for you, a severe. Look at the sunken eyes of my boy and look at this skin pinching going back very slowly. So again, this can be a potential and image-based MCQ sunken eyes and with severe dehydration, again taken from my own clinic. Okay, right. Right. So a small tabular column because so often I have been seeing one question on acute inborn errors of metabolism have been asked. So whenever you have a sick child, whenever you have a sick child with persistent lethargy, persistent refusal of feeds, persistent hypoglycemia, persistent convulsions, persistent vomiting. This is nothing but the feature suggestive of inborn errors of metabolism. Then always you rule out sepsis, then you need to do serum ammonia. When serum ammonia is high, serum ammonia is the next first investigation of choice in any case of suspected inborn errors of metabolism. When serum ammonia is high, look for whether acidosis and ketones are high. When acidosis and ketones are high, along with hyperammonemia, it is organic aciduria. When acidosis is present but ketones instead of high but low means it is nothing but fatty acid oxidation mitochondrial disorders. And finally, when pH is normal, ketones are normal but serum ammonia is high, urea cycle disorders. Bus. Okay, when ammonia is normal, it can be aminoacidopathies or it can be a galactosemia. In galactosemia, one more important clue for galactosemia, it is non-glucose reducing substances are more. So what do you mean by non-glucose reducing substance? Dipstick will be negative, but dipstick will be negative. But what is that another test? Okay. So non-glucose reducing substances. Right. Then what else? So Benedict will be positive, dipstick will be negative. That is non-glucose reducing substance, galactose. Right. Now, now what is this? Now what is this? Congenital adrenal hyperplasia. What is this? Congenital adrenal hyperplasia. Congenital adrenal hyperplasia. Right? So when you have a so ambiguous genitalia or atypical genitalia. Ambiguous or atypical genitalia. Precocious puberty in males can be due to 21 alpha hydroxylase as well as 11 beta hydroxylase deficiency. Atypical genitalia in males, again same, 21 alpha hydroxylase and 11 beta hydroxylase. Hypertension causing congenital adrenal hyperplasia are, okay, what is that? Hypertension causing congenital adrenal hyperplasia are, one is 11 beta hydroxylase deficiency, another is 17 alpha hydroxylase deficiency. Hypotension causing congenital adrenal hyperplasia are star protein deficiency, 21 alpha hydroxylase deficiency, and 11 beta HST deficiency. Antenatal drug of choice is dexamethasone. Investigation of choice is 17 hydroxyprogesterone levels. 17 hydroxyprogesterone levels. What? Ambiguous genitalia or atypical genitalia. Remember, always the most common question will be 21 alpha hydroxylase deficiency in a girl with hypotension. That is the most common presentation. National, so finally, national immunization schedule. Okay, national immunization schedule. At birth, you will give OPV. You give rotavirus 1. You give penta 1. You give PCV 1. You give IPV 1. IPV 1. Okay, at 6 weeks, you give OPV. You give OPV. You give rota. You give penta. But PCV is not given. IPV is not given. Okay, IPV is not given. At 10 weeks, again OPV, rota, penta 3 you will give. PCV 2 you will give. IPV 2 you will give. Booster. Okay. I'm sorry. A little, I'm extremely sorry. Extremely sorry. Okay. So this is take. Okay. So at birth, I'm extremely sorry. At birth, you will give BCG, OPV. At birth, you will give BCG, OPV as well as hepatitis B. At 6 weeks and 14 weeks, OPV, rota, pentavalent. Okay. So at penta, 1, 2, 3, 1, 2, 3. Whereas at 6 weeks, PCV1, IPV1. At 14 weeks, PCV2 and IPV2. At 9 months, OPV you will give MR1, JE1, PCV booster, IPV booster. at 15 to 18 months. At 15 to 18 months. MR at 15 to 18 months. MR2, JE2, DPT booster. Booster at 5 years. DPT at 10 years. TD at 10 years. TD. Okay, and finally TD. And finally, what is this child? What is this child is suffering from? What is this child? Look at the child. What is this child suffering from? Okay, what is this child suffering from? Look at this. The child had, what is this? The child had protruded tongue. Okay, the child is protruded abdomen. The child has puffy face. Child had puffy face. Okay, the child had shrill cry. Child had shrill cry. What is this? This is called congenital hypothyroidism. And remember, they will be asking you about epiphyseal dysgenesis also. INI X-ray knee. What is the investigation of choice? Investigation of choice, either cord blood, TSH, or 72 hours heel prick TSH. TSH will be high and T4 will be low. Most common cause for congenital hypothyroidism is thyroid dysgenesis, in which USG will reveal absent thyroid. USG will reveal absent thyroid. Okay, where you will get goitrous hypothyroidism. You can have, they will give you a picture with the goitrous hypothyroidism. Here you don't have. What are all the conditions that can produce goitrous hypothyroidism? Endemic iodine deficiency. Endemic iodine deficiency. Second one is maternal anti-thyroid drugs. Maternal anti-thyroid drugs. Okay, these two conditions in turn particularly will cause what is this? Congenital hypothyroidism. Okay, congenital hypothyroidism. Apart from that, what are all the other picture based questions they can be asked? Milestones they will ask you with respect to skipping, etc. Okay, what else they can ask you? Developmental, and they can give you a video in which they can give you a, I'm sorry. Okay, they can give you a video in which the child will not be looking into the eyes of the parents. The child will be playing on itself. The child will be playing on itself. So probably it is a case of autism. It is a case of autism. So let me try to show you whether I have some other important exam collections. Some other, once again, some other exam collections. Wait. So look at this. Look at this video. What is this? What is this? So look at the pallor, palmar or plantar pallor compared to my limbs. My upper limb is absolutely pink, but the child's palmar or plantar area is very pale. Why? Why is it so? Oh, what is the hemoglobin? The hemoglobin is less than look at the child's palm and my palm. The hemoglobin is less than 7 grams per deciliter. Severe palmar pallor. So with this, I am completing my session on picture-based, image-based question for you. Thanks a lot for your patient listening. Bye-bye.